Assalamualaikum. Okay, let's start today's recall session. So basically, we are going from what you say from recent to backward. Okay, so we have a January 2024 paper. So we will discuss few recalls from that. Not whole 200 questions we have because there are some repetitions and you cannot memorize whole paper as well. So you just have to have a 3-4 years recalls are enough for exam preparation, and it's just your practice. So recalls are your practice sessions, and even your MCQ books are basically for your practice. So when you first read the theory, you then have to go to practice your MCQs. So we will just do that. Okay, let's start our today's recall session. Okay, so I want all of you to actively participate, and then we will see the answer. Okay, so coming to the first. So frequency of current used in electrosurgery unit is how many hertz it is. 1 kilohertz to 1.5 megahertz, 100 kilohertz to 1.5, 100 kilohertz to 4 megahertz, or 400 kilohertz to 9, or 800 to 9 megahertz. Anybody has any answer for that? Okay. Any guess if you don't know? Okay, so basically we have discussed in our lecture as well that it should not be less than 100 kilohertz. Okay, so that was the thing. So from 100 kilohertz it should be onward. Okay, now in electrosurgery unit basically we use approximately, if you see that it is between 3.3. so B option cannot be, because B and C we have to decide in between B and C. So both are above 100 kilohertz, but it should be at least above 1.5. It cannot be the B option. Okay, so that is why it is a C option. If you see this line from your book as well, so a diathermy machine converts the main low frequency current into a high frequency current in the radio frequency range between 200 kilohertz to 3.3 megahertz. Okay, so that is the reason we are selecting the 4 megahertz up till. Okay, so to obtain a desired surgical effect such as cutting, coagulation, vaporization, and destruction. Okay, so C option is here, correct. What's the most common site for tubal ectopic gestation? This is very, very easy question. So you all must have known that. Which part is your common site for tubal ectopic? The part which would be your ampulla, yes, which would be the widest and where the fertilization occurs. So ampulla is the part where the chances of ectopic pregnancies are very much high, because this is the widest part, and also the fertilization basically occurs here. So that is the reason the ectopic pregnancies mostly occur in this part, ampulla. Okay, so what is the most abundant carbohydrate in the breast milk? Okay, so now the carbohydrate. So we have options in the maltose, galactose, glucose, lactose, and sucrose. Yes, lactose. So basically the lactose is actually present in the breast milk. If you see this table, it is from your book. So in breast milk, we have energy of 75 kilocalories per 100 ml, and protein is 1.1 gram. And protein, we have two types of proteins. This question can also come like this, that which is the abundant protein in the breast milk? So casein and whey protein both are basically the predominant, but between these two, whey protein is more. So 60% of protein is whey protein. So you have to remember this proportion as well. Now the lactose. So basically in the carbohydrate is main is the lactose. So lactose is 6.8 grams, and fat. If you just see the contribution of these three, protein, carbohydrates, and fat. So carbohydrates are abundant in 6.8 grams. Then we have fat, and then we have protein. So again, there was a difference between breast milk and cow's milk as well. So in the cow's milk, basically protein is more than the breast milk. So that is the differentiating point between these two. So sodium is 7 millimoles, chloride is 11 millimoles. So these three things are important. Okay, so lactose. Okay, so which of the following structure, when dilated, produces caput medusae? Okay, caput medusae, who will answer? That is okay. So see, if you just go there, we have discussed this thing as well. So what happens in the portal venous obstruction is that the superficial veins which are around the umbilicus. Why it is not? Just a minute. I am just selecting two fingers to scroll up anywhere. Okay, I have to tap first. Mm, that is a difficult thing. No, just forget this drawing. Okay, so what happens in portal venous obstruction is that the superficial veins which are around the umbilicus and the paraumbilical veins, basically they are grossly distended. So you have the option if paraumbilical veins or the umbilical veins both can be corrected. So in these options, hepatic, splenic, ductus venosus, umbilical arteries, and umbilical veins. So umbilical veins are the correct because these distended subcutaneous veins, they radiate out from the umbilicus and they produce this clinical picture which is called caput medusae. Okay. Okay, so nifedipine belongs to which class of drugs? This is very easy. Potassium channel, sodium channel, calcium channel, ARBs or ACE inhibitors. So that is very easy. Yes, it is your calcium channel blockers. Okay, that's correct. And now the forest plot. So forest plot horizontal lines represent. Basically, in statistics, they can ask you some few odd things as well. So just see this forest plot. What actually is this forest plot? In this forest plot, the horizontal line, it shows this confidence interval. So this is a 95% confidence interval is here. And you have to select where the confidence interval for each study is represented by horizontal line and point estimate is represented by a square. So the estimate of, you can say that the ratio or this interval, it would be selected by this square, which is shown in this graph. Okay, so you don't need to go into very detail of this forest plot. Just remember that, okay, what is in the horizontal and what is meant by the that square. Okay, so 16-year-old has recently become sexually active and she complains of intensely irritating greenish frothy vaginal discharge. The organism is seen under microscope in drops of saline and the pH is 6. I think it's removed. So pH is basically 6 here. Okay, so what is the most likely causative organism? So who will tell me? Candida, chlamydia, Gardnerella vaginalis, Trichomonas vaginalis, or Treponema? Uh, B. Okay, how you select the B? Chlamydia? No, C. Gardnerella vaginalis. Okay. If you have selected this BV, like bacterial vaginosis, the disease, so what is that diagnostic feature of that Gardnerella vaginalis? Is it visible under the microscope? The organism is seen under microscope, and the pH is 6. Yes, pH would be 6, means more than, not acidic pH would be in both these two conditions. Yes, clue cells. If you have clue cells on the microscopy, then that is the significant. That is the uh, pathognomonic of Gardnerella vaginalis and bacterial vaginosis. But if you see any organism, sometimes they say that the flagellated organism is seen. So it would point out to the Trichomonas vaginalis, okay? And also the greenish and frothy vaginal discharge is actually the typical of Trichomonas vaginalis. So let's discuss just briefly these infections we have discussed already. So we have these three infections, Candida, BV, and TB. So in Canada, you know that 80% is due to albicans and rest 20% due to Glabretta cruzi tropicalis. BV shows Gardnerella vaginalis and Trichomonas vaginalis is the flagellated protozoa. Now the most common, because Canada is in the high estrogen condition, so pregnancy, OCPs, diabetes, and immunocompromised conditions, these types of conditions would be linked to the Canadal infection. And BV, if they ask you the most common cause of abnormal vaginal discharge, that would always be BV. Okay. In these, out of these three, only the Trichomonas vaginalis is the sexually transmitted disease, and you have to screen the partner and treat as well. And the pH in Canada, I the pH would be remains acidic. Okay, so pH would be normal. So 3.5 to 4.5 is your normal vaginal pH. And in BV and TV, both they rise the vaginal pH because they suppress this lactobacilli. So that was actually secreting the making the acidic pH. So in both these conditions, your pH would be high, not acidic. So above 4.5 would be pH in these two conditions. Now the symptoms and signs, you know that in Canada we have curdy white discharge, itching, soreness, redness of vulva would be there. And in BV and TV, you will be having a discharge. Now in BV, they are this is the pathognomonic, like if they say you the fishy smell link discharge. Okay. So this is very typical of bacterial vaginosis, which is thin, homogeneous, adherent to the walls of vagina. And in Trichomonas vaginalis, often they say that purulent green or yellow discharge, and sometimes they also say that there's a strawberry cervix. Okay, so these two are the typical features of Trichomonas vaginalis. Okay, so the diagnosis in the candidiasis, we have microscopy, and you are no longer doing culture for that because you all know that this Canada is already a carrier. In 25% we are carrier to this, so it is already present in our vaginal flora. So microscopy is required for that. And in bacterial vaginosis also microscopy, and in TV microscopy and not. Okay, so these three are diagnostic features. Now the in microscopy of Canada, you would see the pseudo hyphae are seen, but in BV, this is the criteria that is very important. So AMSIL criteria is important. You need to remember that. What is criteria? So this criteria has 4 points. So first is vaginal pH would be above 4.5. And then second is your fishy smell. See, again, the fishy smell was of the discharge. And now whenever you add the alkali, you have a release of fishy smell. And the discharge would be seen on the examination and the clue cells. So clue cells is very typical of this BV. Okay, so now in the TV, this motile organism would be identified from its shape and the 4 flagella. So whenever they say that it is a flagellated organism, you have to select this TV. And also this is the gold standard here would be the NOT. NOT is actually your nucleic acid amplification test, and that is high sensitivity. So this is the gold standard of TB. Culture is no longer recommended in almost all 3 conditions now. Okay, so the treatment would be in Canada, you know that you have to give antifungals in the form of pastry or in the form of oral. And in pregnancy, again, you can use the pastry. In BV and TV, the dose is almost same, and you give metronidazole. Okay, so let's move on to the next, where in the kidney is the majority of bicarbonate absorbed. So basically in the kidney, majority means all of the solutes, they absorb at only one place, and that is your proximal convoluted tubule. Yes, great. So whenever they ask you the majority of bicarb or anything they ask you, so basically all the solutes they absorb in the proximal convoluted tubule. Okay, so now the choriocarcinoma, it's a malignant form of gestational trophoblastic disease. When it metastasizes, it has a propensity for which type of spread? Now, the spread of this choriocarcinoma is by direct invasion, hematogenous, lymphatic, surface implantation, or transcoelomic. So this choriocarcinoma is actually a malignant, yes, hematogenous, yes, great. So it actually transfer to the in the blood. Okay, So what drug can be given to reverse myelosuppression in methotrexate toxicity? Whenever, even in the choreo, or you can say in the methotrexate, whenever you give an methotrexate IM, what you give additional to that? After 30 hours, you give one thing that is very important, because you give to suppress the, to reverse the myelosuppression, because methotrexate can suppress the, can do the myelosuppression. Yes, folinic acid. So you have to select this folinic acid. It is used for to prevent the myelosuppression. Okay. So now a patient presents with condyloma lata. At which stage of syphilis this does this feature occur? Now you have to know the all the features of all the stages of syphilis. First is primary, then secondary, then tertiary, and tertiary also, then neurosyphilis, cardiosyphilis, those were present. So what happens in this secondary syphilis, primary syphilis? Any guess? When the condyloma, the wart-like lesions, they appear in the syphilis, at which stage of syphilis? Okay. So if you see this, you must know that in the primary syphilis, we have, we say that, okay, this is a chancre, a painless ulcer, not a painless, painless. So a painless ulcer would be appearing in the primary syphilis, and then that ulcer heals, and then this secondary syphilis, it actually arise as a primary chancre. Chancre is that the painless ulcer. So it is healing, or up to 6 months thereafter. So approximately 6 months after primary syphilis, you get secondary syphilis, and this is your systemic disease. Now it start as this maculopapular rash, and then this rash is symmetrical and involves the palms of hand and soles of feet, and also the intertrigonous areas, mainly the perianal area. And then also it it flourish, and it wart-like lesions called condylomata lata, it appears. So this condylomata lata is actually the stage of secondary syphilis. It appears in this stage. And also there would be generalized lymphadenopathy. So in secondary syphilis, three things would be there. It is actually a systemic disease. So first would be the maculopapular rash, then you can say condylomata lata, and then the generalized lymphadenopathy. So these three features would be your secondary syphilis. Okay, so the epithelial lining of mons pubis is which of the following tissue types? Either it is transitional, stratified squamous keratinized, non-keratinized, stratified columnar, or simple columnar. Okay, so this is, I think, very easy. The epithelium is, yes, stratified squamous keratinized. Okay, so all the external, you can, the skin, basically the skin is, epithelium is stratified squamous keratinized. So the B is correct option. Okay, so which of the following the circulatory blood cell that is capable of differentiation into plasma cells? So you all know that how plasma cells are formed from which cell? Neutrophils, basophil, monocytes. So these three are not, basically, so B lymphocytes and T lymphocytes. So B and T, which would be forming the plasma cells, the antibodies would be secreting from that. So basically it is B. B lymphocyte. Okay, you are saying B. Yes, not option B, but B lymphocytes. Yes. Yes, that's great. Okay, so what is the most common type of episiotomy which is performed in the UK? So which kind of episiotomy we are currently doing? So one is mediolateral, then there is a median episiotomy. Median would be in the middle, and then there's a paramedian episiotomy, and lateral or J-shaped. Yes, great. Mediolateral episiotomy is used. Okay, so what is the embryonic origin of trigone of urinary bladder? Okay, so trigone. Mesonephric duct, paramesonephric duct, ureteric bud, urogenital sinus, caudal of cloaca. So who remembers embryology up till now? A. Yes, that's great. So basically, all your urinary system, urinary bladder, it is actually developing from the urogenital sinus. But why the trigone is actually different. So trigone embryonic region is different because you know that in that trigone area, your both the ureters, they are opening into the bladder, and you know that ureters, they are formed from the mesonephral ducts. So mesonephral ducts, they actually incorporate into the bladder wall. So that is why that area of trigone is actually formed from the mesonephral duct. Okay, that's great. So oxybutynin hydrochloride, a non-selective muscarinic receptor antagonist, used to treat bladder overactivity. Which of the following disease can be aggravated by use of this antimuscarinic? So you know, must be knowing that okay, these antimuscarinics, when are they contraindicated? So bronchial asthma, closed angle glaucoma, diabetes, Parkinsonism, peptic ulcer. Closed angle glaucoma, I guess that's great. So bronchial asthma, if you just remember that in every kind of respiratory disorders, your beta blockers, basically they would be contraindicated. Okay, but these antimuscarinics, they are actually contraindicated in closed angle glaucoma because they can aggravate this intraoptic pressure. Okay, so which nerve arises from ventral rami of lumbar plexus and then it emerges from the medial border of psoas major muscle. Okay, so basically all these are, I think, from the lumbar plexus, but they have specified that which emerges from the medial border of psoas major muscle. If you remember that we said that all, I think, they are passing from the lateral border, except one thing, one nerve passes from the medial border and one nerve pierces the psoas muscle. So if you remember anything, femoral, genitofemoral, lateral femoral cutaneous nerve, common peroneal, or obturator nerve. Okay, the option arises first. Okay, so this was the lumbar plexus we have already discussed. So originates from, you know, L1 to L4. And if you see this, that it traverses the psoas major and emerges from its lateral borders, except, so exception, these two things you have to remember. So obturator nerve, basically it emerges from the medial border of psoas major muscle, and the genitofemoral nerve, actually it emerges from anterior aspect of the muscle, so it pierces the psoas major muscle. So this is exception, these two things. And if even if they ask you the rest of the nerves, then they are emerging from the lateral border. Okay, so what is the most common cause of secondary hyperparathyroidism? So secondary hyperparathyroidism, parathyroid adenoma, multiple myeloma, sarcoidosis, chronic renal failure, or man type 1. Chronic renal disease. Yes, that's great. So if they ask you about the primary hyperparathyroidism, most common cause, and that would be your parathyroid adenoma. Okay, but the secondary cause, where when the renal functions are destroyed. So chronic renal failure would be your most common cause of secondary hyperparathyroidism. Okay. So ADH is released from which part of hypothalamus? It's arcuate nucleus, preoptic, periventricular, suprachiasmatic, supraoptic, and paraventricular. So these nucleus are also very important. They usually ask about ADH and oxytocin. These two hormones are important. So you need to remember. So which part of hypothalamus they are secreting? And that is, okay, so basically it is a supraoptic and paraventricular. And from these two nuclei, this ADH hormone is released. Okay. So now an important question. So basically it is your HPV screening profile, and we have discussed, I think, in our last lecture as well. So these are the findings you have get, and now you have to interpret the result. Okay. So I want to draw something. Cannot. Okay. Okay. That's right. Okay. So first you see the result. The first is HBs antigen positive. Okay, so we have discussed in our previous that whenever you see that this HBs antigen is positive, it means there is an infection either in the form of acute or in the form of chronic. Okay, so just step by step, so see all these parameters. So if you first see that HBs surface antigen is positive, it means there is a current infection is ongoing either in the form of acute infection or in the form of chronic infection. Okay, now in the next few steps you have to differentiate between these two things. So anti-HBC is positive. The second thing, it would be positive whenever there is a past infection, it would be positive. Okay, so it is also showing that okay, there is some kind of infection. And this anti-HBC IgM is negative. Basically, this IgM is actually your differentiating part in the acute and chronic. When this IgM would be positive, then it is an acute, and in chronic, it would be negative. Okay, so this would be differentiating point of acute or chronic. And this NHBe antigen is negative. This is actually the highest transmission rate, transmission of the infection. Anti-HBe is also positive, and HBV DNA is positive. This is the title of the HBV DNA. So 203 is present. So just by looking at the first 2-3 things, you can diagnose that either it is acute infection or a chronic infection. Okay, so yes, this is they say that HBs antigen is positive. It means acute current infection, either in the form of acute or chronic. Anti-HBs, if it is present, it indicates immunity. Okay, so anti-HBs, these two things would be, you can say that opposite of each other. Whenever the surface antigen is positive, it means there is a current infection, and whenever this is negative and anti-HBs is positive, it means you have been now imbued either due to the infection, the previous infection. After this infection, you are immune, or you are immune due to some vaccination. Okay, so these two things are your clue for the for selecting the option. So IgM anti-HBC, it is actually, it would be differentiating between acute or chronic. So whenever it is positive IgM, it shows recent infection means acute infection. And whenever this anti-HBC is positive, it shows that he or she has ever been infected, like there is some kind of infection in the past. So if you want to differentiate, see these 4 kinds of conditions you get in exam, either in the form of acute or chronic infection. So whenever they give you acute infection, so just look up the this scenario. So only one thing would be changed. This IgM negative would be your positive, and that will be showing that okay, this is an acute infection. So acute and chronic, and the second one would be your uh, immune due to infection or immune due to vaccination. Now immunity will be showing by anti-HBs would be positive, so the second thing would be positive in that. And you differentiate between these two things either due to infection or vaccination by looking at this anti-HBC. So both antibodies would be showing your immunity status. So anti-HBC positive means that she has been infected. So it is positive in the infection, and it is negative whenever you have vaccination. Okay, I hope you have understand this thing, that how to correctly solve these kind of questions. These are very, very important, this HB serology. Okay, so now the next is actually your pathway of piriformis. You have to select that how the piriformis muscle, it is origin, it exits, and how it is inserted. These 3 points would be there. So the options are, first they are arising in the ventral surface of sacrum or dorsal surface of sacrum. So these 2 kinds of options you are getting, and then they are exiting pathway, how it exits, from where, either from the greater sciatic foramina or from the lesser sciatic foramina. Okay, so these 2 things, and then the insertion. So these 3 things they have asked you in the same one question. So first is the origin, second either from ventral or dorsal, the exit pathway from greater or lesser sciatic foramina, and the third is your insertion on the greater trochanter or on the lesser trochanter. Okay, so these three things you have to remember in the piriformis. Okay, so which D option? Who is saying D option? D option in this or in the previous? In the piriformis muscle, you are saying that option D is correct. So, yes, A. So basically, what is the difference between A and D? One is saying A and one is saying D. Okay. So one A shows that ventral surface of sacrum, greater sciatic foramen notch, and greater trochanter of femur. So greater trochanter. D option shows the dorsal surface, greater sciatic notch, greater trochanter. So only the difference is between ventral and dorsal surface. So these two things are corrected, that it exits from greater sciatic notch and it inserted in the greater trochanter of femur. Those two things are greater. But the origin is ventral or dorsal. So basically the ventral surface of sacrum, all the nerves you can say they're emitting from the ventral side. These ventral rami kind of thing you can say. So the ventral surface of sacrum would be there. So option A would be correct. This is a very important table. You have to memorize this greater sciatic foramen and lesser sciatic. So just see that pudendal nerve in both these things, pudendal vessels are also both this. And the two things, muscles are just two. One is the piriformis muscle and the second is the obturator internus tendon. Also, you can say this muscle basically. So this piriformis is your greater sciatic and obturator internus in your lesser sciatic. Okay, so rest of all the nerves which are actually they want to go to, those nerves which have to go to gluteal region, those will be exiting from the greater sciatic foramen. So sciatic nerves, superior gluteal, inferior gluteal, femoral cutaneous, obturator internus, quadratus femoris, superior gluteal artery, and inferior gluteal artery. Okay, so in here only the pudendal vessels and the nerve to obturator internus, because this the muscle is here. So this is a very important table. And if you see this pelvic muscle, so the origin is piriformis, front of sacrum. So front of sacrum means the ventral surface. Greater trochanter of femur, it is inserted the sacral plexus and it is actually a lateral rotator of femur. Okay. So, what is the most common cause of Cushing syndrome? Either it is administration of synthetic ACTH, paraneoplastic syndrome, pituitary adenoma, or iatrogenic steroid administration, or adrenal adenoma. So, what is actually the most important, most common, basically, not important, most common cause of Cushing syndrome? D, yes, iatrogenic. So basically, the iatrogenic steroid administration is the most common cause of Cushing syndrome. You have these tables in your book. So overall frequency, if you see that the common, like 99% of cases, you have exogenous therapeutic glucocorticoids. And uncommon, you can say that, okay, pituitary adenoma, ectopic production, adrenal adenoma. Okay, so you have to just remember the most common cause. And that is your iatrogenic or therapeutic steroids, which you are taking in the form of any treatment. Okay, so nitrogenous bases make up cellular nucleic acids, and okay, which base pairs with adenine in the standard DNA helix? So A pairs with, so very easy. A is with thymine, basically. Yes. Okay, so A pairs with thymine. If you see this diagram, A pairs with thymine and the G pairs with cytosine. And the hydrogen bond, you also need to remember that there are two hydrogen bonds between A and T and three hydrogen bonds between G and C. So GC add GC, like GC college. Okay, so which of the following HPV subtypes is high risk for the development of warts? So they are asking you about the warts. Not you just see that this is a high risk word and you just select one thing. So we have two kinds of you can say HPV types. One is the high risk and one is the low risk. Okay, so see 611. So basically 611 are called low risk. So low risk, they are called low risk for cervical CA. That's why they are called. But they are actually causing the genital warts in up to 90% of cases. So this is high risk for genital warts. So these low risk, if you see that 6 and 11, they are found in the 90% of warts, and 16 and 18, they are actually most common high risk types, and they found in over 70% of cervical cancer. These two percentages are important. Low risk type are causing warts in 90%, and high risk types are causing in just 16 and 18, they're causing 70%. Other high risk types are also present, but you don't need to remember all those. Okay, so what is the function of DNA polymerase? To unwind the DNA helix during replication, to add nucleotides to the end of template DNA, to synthesize the nucleotides of DNA strands, to seal together the broken ends, to proofread the growing DNA strand. Okay, so just these, for every this function, you have a specific enzyme for DNA synthesis, and that is, if you see this, we have okay. So what it does, it actually, so basically, first one is your helicase. Helicase actually, it unwinds the DNA. Okay, so open up the DNA. So that is helicase. Now the DNA polymerase. So basically, it adds the complementary nucleotides. So basically, it is adding the nucleotides on the strand. We have two types of strand. One is leading strand, and one would be the lagging strand. You don't need to go into very detail. Just if you see this diagram, this is the helicase, which actually open up this DNA, and this DNA polymerase, it is actually adding the nucleotides, and it always function in this direction, 5 to prime to 3 prime direction. So this is the difference characteristic, that it always function in this direction. Okay, so which of the following is the genotype of Turner syndrome? So Turner syndrome, you all know that in the Turner syndrome we have one absent chromosome. So that would be your 45, and that is your X would be absent, so it is X0. So 46XX is your normal female. If you have 47XXY, that would be your Klinefelter. So these thing you need to remember. 47XX, it means that one is additional, but it is not X, so it must be some kind of trisomy in the form of Edward, Down, or anything. And this option is actually wrong. 46XX plus 18, it cannot be right. So it means, again, it is 47XX plus 18. It means this would be a female Edward genotype. Okay, so this is how you have to, they can ask you anything like, okay, what is the genotype of male Edward, female Edward, male Down, female Down. So the genotype of male female remains the same in trisomies, just they add additional things, that okay, the 18 is your Edward, so one extra copy of Edward is there, or one extra copy of 21 is there. So the total number would be 1 plus, so 47. Always there would be 47 there. Okay. Okay, so coming to the next scenario, so here, so this is a very important, the RMI. We have discussed in our last lecture that you can get one question on this RMI and you have to calculate. So the RMI, how you actually calculate, it is three things: U, M, and your CA125. Okay, if you just see the question, she's bloating which showed bilateral ovarian masses, no solid areas, abdominal ascites. Two things are present, no solid areas are not. But a characteristic feature, ultrasound feature. So we have actually 5 ultrasonic features, which according to which we score. Like if you have only one ultrasound feature, your U score would be 1. If you have 0 can also be there. If you have no ultrasound feature, your score would be 0. And if you have 2 or more than 2 ultrasound features, your score would be 3. Okay, So here in this case, you have two ultrasound features, like you have a bilateral and also the ascites. Okay, so the next thing is, so ultrasound score is your 2. Now the next is M. M is your menopausal status. So postmenopausal, you select the score is 3. And if it is premenopausal, you have to select 1. Okay, and now the CA1 to 5. So what is the number of CA1 to 5? It is actually your 50. So you just have to 1, 2, oh, sorry, 3. This is 3 actually. I have written it wrong here. So whenever ultrasound score is, whenever you have 2 or more than 2 ultrasound features, your score would be 3. Okay, so this is actually 3. Rewrite this. So this is actually 3. So 3 into 3 into 50, that is your RMI square. Okay, so in these options, you would be having 3 into 3, 9, so 450 would be there. Okay, so we have discussed. So basically, these are the 5 features of ultrasound, from which you have selected. So one is multilocular, then the second is your, it is not multilocular solid areas, metastasis, ascites, and bilateral regions. Okay, so these 5 are the 4 points. Okay, so the next question is a 45-year-old woman undergoes pelvic operation and post-operatively she develops shortness of breath. Chest X-ray reveals hilar vascular marks with mild pleural effusion. Her blood investigations shows sodium 110. Okay, sodium is very much less. Potassium 4 means normal. Bicarb 24, urea 3, creatinine 20. It's also high. So, what is the most likely diagnosis? So basically, in the post-operative state, if you just rule out the options from this, okay, so the renal failure is not actually here. Renal failure is, there's no feature of that. Pneumonia, you don't have any kind of picture in the renal pneumonia as well. Pulmonary edema, you can select this. The pulmonary edema can be happen because, but they have said you only vascular marks and mild pleural effusion. Okay, so the adrenal insufficiency don't have anything because in that would be your potassium would also be lower, and in the syndrome of inappropriate ADH secretion. So basically, this SIADH is actually the your important thing because it usually the ADH is secreted excessively in the whenever there's any kind of stress or surgery. So post-operatively, you can have this kind of thing because why the sodium, only the sodium is reducing, because what happens is that your ADH, whenever your ADH is rising, it actually increases your water absorption. So your water absorption is more. So whenever the water absorption is more, it means your solute concentration or osmolality would be decreased because water is more. So that is why the sodium is very much less. So this is actually your syndrome of inappropriate ADH. So if you see this vasopressin, so basically this vasopressin ADH is actually your regulator of water. Okay, so it increases the permeability of distal tubules and collecting ducts of kidney to water, and that's how the water reabsorption, so urine volume decreased, and it actually effect of reducing the plasma concentration. So osmolality actually reduced and the blood volume is increased. So they have used stimulants of AVP release whenever you have increased osmolality or you have reduced blood volume. Okay, so these two things are very important. Whenever the volume fluid is reduced, then this ADH would be rise. Whenever you have high solute concentration in your body, like in the form of increased osmolality, then this AVP would be raised. And also after any kind of stress, pain, drugs, any kind of surgery, nausea, vomiting, and alcohol is the inhibitor of this. Okay, so at what level bifurcation of common iliac arteries occur? Okay, so this is an important thing. Bifurcation. So basically, bifurcation of aorta is at which level? First, tell me this. At which level aorta bifurcate, and then at which level this common iliac artery bifurcate. So these two levels are important. ED Aorta, aorta bifurcates at L2 or L4? Check it again. I think aorta bifurcates at L4. Okay, so anatomy. See the bifurcation of aorta. So the bifurcation of aorta is actually your L4. So it means that at L4 your aorta bifurcates, and it bifurcates into common iliac artery right and left. So basically these two common iliac arteries, they are arising at the level of L4, but they are ending, like whenever they bifurcate into right internal and external iliac artery, that is actually your level of you can say that at the sacroiliac joint. So you can select L5 or S1. So basically S1 you can see what's happening. Okay, so the aorta bifurcates at L4 and common iliac bifurcates at S1. So sacroiliac joint can say the level is S1. Okay, so it commences at the level of L4 and it ends at the level of L5 S1, and bifurcation at the sacroiliac joint. So both these things are same, L5 S1. Okay. Okay, so the next question is your 18-year-old woman is found to have a large neoplasm, and now the tumor marker. So these variant tumor markers are very, very important. You have to remember. So only tumor marker raised is your LDH. So LDH is raised in which neoplasm, ovarian neoplasm. The rest of HCG and alpha fetoprotein are negative. See, in the less than 40 years women, we have discussed in our previous lecture that in younger women, you don't need to go for the, you don't go for CA125. So in younger age women, you have to go for LDH, HCG, and alpha fetoprotein because your germ cell tumors are very, very common in this age group. Now the LDH. Who will tell me? The LDH is raised in which tumor? Theca cell tumor, dysgerminoma, immature teratoma, Brenner cell tumor, endodermal sinus tumor. In which tumor? Endodermal sinus tumor. Okay. And dysgerminoma. Yes. Basically, LDH is raised in your dysgerminoma. So these five things are important. You just remember these. So your yolk sac tumor, whenever you have this yolk sac tumor, then alpha fetoprotein would be your tumor marker. Choriocarcinoma, you already know that it is an HCG, and dysgerminoma is your LDH. And the embryonal carcinoma is your HCG and alpha fetoprotein, both can be raised. And granulosa cell tumor, we have inhibin. Okay, so these five things you have to remember by heart. Okay, so coming to the next slide. Okay, so basically you have, whenever you cut a medial lateral episiotomy, so which muscles actually you are cutting? They are asking this thing. Which perineal muscles you are actually cutting? Option A, hydori. Okay. So basically it is a bulbous, if you see the bulbous spongiosis and ischiocavernosus, two options are right here. So you know that bulbous spongiosis would be here and ischiocavernosus is just in the, if you just remember the clitoris, so ischiocavernosus was here and bulbo was on the two lateral sides. So medial lateral episiotomy, you are actually cutting the bulbous spongiosis. And now there are two transverse perineal muscles. So one is your superficial and one is your deep transverse perineal muscle. So you are not cutting and going into the deep transverse, but superficial. Okay, no, superficial and deep, sorry. So basically the bulbospongiosus and deep transverse perineal muscles, they are actually cutting in this mediolateral episiotomy, yes. Okay, so which antibody, which antibody class, okay, is involved in allergic reactions? So this is an easy thing, you know that which immunoglobulin is involved in allergic, so it is your IgE. Okay, So, which immunoglobulin is primarily secreted in cervical mucosa? Cervical mucosa. And that is your IgA, basically. So, IgA is actually present in the cervical mucosa. I'll be discussing the immunoglobulins later on as well. There's another question. So, most likely histological subtype of vein cancer associated with endometriosis. So, endometriosis has association with which type of cancer? So, that is your great. So, clear cell carcinoma is pathognomonic of this endometriosis, you can say. Clear cell. It's great. Okay. So, the next again, I think okay, no, this is a different question. So here the patient presents with fishy, foul smelling odor and also the clue cell. So basically they have given you two clues. So the most likely organism would be, now you know that which organism is present here. So it would be your Gardnerella. Yes, great. Okay, so what is the embryological origin of lateral vaginal wall cyst structure? So whenever you have a lateral vaginal wall cyst, which is actually your you can say this is your Gartner duct cyst. So, what is the embryological origin of this Gartner duct cyst? That is your mesonephric duct. Yes, that's great. This table is very, very important. You need to remember this table that one thing is homologous structures. You need to know that this is like homologous structures means the same embryological origin and they are differentiating into male, either male or female. Like if you just see that this prostate gland, it is very unique. It is in the male, and in female it forms urethral and paraurethral gland. So they can ask you that, okay, which organ or which structure is actually homologous structure of prostate gland. So you need to remember like this, that what is developing into which structure. So mesonephric, you know that tubules, they are forming this apophron, paraphron, and also the ductules. So this mesonephric duct, it is actually your Wolffian duct and it is developing your male genital tract mostly. All the epidermis, ductus deferens, ejaculatory duct, seminal vesicle, and also the so basically this is your male genital structure, and also the urinary system is in the both male and female. Ureter, pelvis, calyces, collecting tubules. And the paramesonephric duct, it is forming the uterus and hydrated, and this is the remnant. They can ask you that what is the remnant of paramesonephric duct in males. So paramesonephric duct remnant is your appendix of testes, and mesonephric remnant is your apophron. Tubules, if they ask you tubules, then it is would be apophron. If they ask you about mesonephric duct, it would be duct of apophron. Okay, so this is a little minute difference between these two things. So these two remnants are very important, appendix of testis. And if you see this urogenital sinus, you know, the bladder, urethra, their vagina is forming from this, and here also this. Then the genital tubercle is forming into clitoris, glans, penis, and glans, penis, urethral folds, labia minora, and ventral aspect of penis. Genital spirings, they form labia majora and scrotum. So basically scrotum and labia majora are homologous structures. Okay, so this is how they can ask you in exam. So this table is very, very important. Okay, so what percentage of thyroxine hormone is free? Like 0.1%, 1%, 5, 15, or 70%? Okay. Okay, so basically, if you see this structure, 0.1%, yes, that's great. So this is important thing to remember, 0.1% of T4 and 1% of T3 are free. Okay, so these two percentages are very important. What is the second most common cause of congenital adrenal hyperplasia? First, tell me what is the most common cause of congenital adrenal hyperplasia. So first common cause and second common cause, you need to remember these two things. So first is always your 21 hydroxylase deficiency. This is important actually for exam. So 21 hydroxylase. But there's also a second most common as well. So that is your 11 beta hydroxylase. Okay. So these two things are Important, yes. So it's the anatomical location of Bartholin glands. You need to remember that Bartholin glands are located where? Either in the deep perineal pouch, ischiocrectal fossa, renal canal, superficial perineal pouch, or your gentle diaphragm. So basically, it is located in some kind of pouch, either in the deep pouch or in the superficial pouch. Okay, so select from these two things. A, where A option? Point one, then C. Deep perineal pouch, you are saying? Okay, no, just see this diagram as well, and also the superficial perineal pouch. So you know the superficial perineal pouch, it is bounded below by the membranous layer of fascia and above by the urogenital diaphragm, and these are the important contents. So superficial perineal muscles and bulbospongiosis would be in this pouch, then the ischiocavernosus muscle, and then this Bartholin gland is actually present in this superficial perineal pouch. Okay, so this is thing they are asking. So most common cause of postmenopausal bleeding. So most common cause. So always the most common cause you need to remember everything. So either it is atrophic vaginitis, endometritis, CA, hyperplasia, polyp, or HRT. So yes, it is atrophic vaginitis. So which ECG leads represents inferior wall MI. So these two, three things are also important to remember how you diagnose on ECG. So inferior wall, lateral wall, and you can say the anterior wall MI. So we 1, 2, 3, 4. These are your chest leads, so these are your anterior. And then yes, 2, 3 AVF is your inferior wall MI. If you just see this figure as well. So 2, 3 AVF are your inferior wall. This V1 to V4, this is your anterior wall. And then this is your lateral wall, 5 and 6, and also 1 and AVL. So 1, 5 and 6, 1 AVL, 5 and 6 your lateral surface. So either they can ask you the lateral wall MI, then interior wall MI, or inferior wall MI. So these three you have to remember. Okay, so here's a patient just taking lithium. So which abnormality can be occur in the fetus? So lithium is very lithium abnormality is pathognomonic, very typical. So tetralogy of Fallot's, Dandy Walker, Epstein anomaly, limb reduction, renal agencies. Yes, Epstein anomaly. So Epstein anomaly is very pathognomonic of lithium. Okay, so mechanism of action of atosaban. So atosaban is your calcium channel blocker, GnRH analog, antagonist, or oxytocin agonist or antagonist. So this is also an easy question. Oxytocin antagonist. Yes, that's great. So which type of vaccines are absolutely contraindicated during pregnancy? Either kill, toxoid, conjugate, live, recombinant DNA vaccine. So we have absolute contraindication to D, yes, live attenuated vaccine. They cannot be given in pregnancy. So terbutaline is your, which it acts on which receptors? Alpha, gamma, beta 1, beta 2. So actually it is beta, but which beta? 1 or 2? Beta. Beta 2, yes, great. So it is actually beta 2. Okay, so now gonorrhea. So gonorrhea can be described as what? Okay, so see, gram negative and positive, they are asking first negative or positive. Then they're asking about aerobic and anaerobic. And then they're asking about cocci or bacilli. Okay, so you have to select like this. So you know that it is a gram negative. This is easy thing, and you know that it is a cocci. But aerobic and anaerobic you need to remember. So basically, it is most commonly it is an aerobic, but it can occur as also the anaerobic cocci as well. Okay, so gram negative aerobic cocci. Okay, so which of the following nerves enter the thigh by passing beneath the inguinal ligament? So which passes beneath the inguinal ligament would be which nerve? Your femoral, your hypogastric, your inguinal, genitofemoral, or lateral femoral cutaneous nerve of thigh. So basically, it is passing beneath the inguinal ligament and it is going to the thigh basically. Ilioinguinal is not going through below the inguinal ligament. Ilioinguinal is, I think, going through the inguinal ligament. that is different thing. So here it is actually your lateral percutaneous nerve of thigh, which is going behind the inguinal ligament, beneath the inguinal ligament. Okay. So if you have examined the uterus and it is enlarged and your biopsy shows endometrial glands in myometrium. So whenever you have the endometrial glands in ectopic position, like in myometrium, so ectopic, whenever the endometrial glands, it is actually your adenomyosis. And when these glands appear in the myometrium, then this is called adenomyosis. Okay. Okay, so for RNA analysis, which test to be used, be northern, southern. This is important now. This table is important. So southern blotting is used for DNA, northern blotting for RNA. These two things you have to remember. Western blotting for protein. Where's protein? This is protein. And PCR whenever you want to amplify. So these few points you need to see that what point they are asking. Whenever they're asking you about the amplification of a specific sequence, you need to select the PCR. And rest of the things you need to select accordingly by DNA, RNA, or protein. So which type of necrosis is actually seen in heart after an MI? So this table is very, very important. Necrosis. So there are 5 types of necrosis we have discussed in pathology. So after MI, it is actually organ specific. It is a coagulative necrosis. Yes, that's great. So coagulative in MI, if they're asking you about brain necrosis, polypoetic, caseous in tuberculosis, gangrene, clostridial, and fat necrosis in acute pancreatitis. So these 3 are very important: MI, cerebral, and fat necrosis. Okay. So which has the dimeric structure? Dimer. So all these immunoglobulins, if you see this table, so this table is very, very important. Okay. So if you just see, don't need to remember the weight, just have to remember the structure. Okay. 2 things are unique. All are monomer. If you just see this, everything written here is monomer. Just 2 exceptions are there. IgM is pentamer and A is dimer also. Okay, so these 2 things you have to remember. So again, the functions are written, you know very well, on mucosal surfaces. We have discussed the cervical mucosa as well. Okay, so that is why they are called IgA was present here. Okay, in the secretions, and it is secreted in breast milk. D has no role except the antigen receptor. E in allergic response. G is your crossing the placenta and most common antibody. IgM is actually your first antibody to be synthesized by neonates. So these 2 points are very, very important according to neonate. IgG is actually crossing the placenta and M is actually synthesizing by the neonate. Okay, so this is the your immunoglobulin. So which of the following is major buffer in urine? So you need to remember these buffers as well, which is most common in urine, blood, and bone, intracellular fluid, and interstitial fluid. So this table is important. E in which option? Buffer? You are saying E. Or the above option was A. No. So basically you need to remember just this table. Okay, so whenever they ask you which is the major, okay, so major buffer in blood, it is not right. So major buffer in blood would be from B, bicarbonate. Whenever they ask you urine, then it should be phosphate. Bone is calcium carbonate. And intracellular fluid would be the protein and phosphate. And interstitial fluid would be bicarbonate again. Okay, so these are the 4-5 things you need to remember. So bicarbonate, phosphate, and protein buffer. These 3 are very, very your most common, you can say. So bicarbonate is your blood, phosphate is your urine, and protein is your intracellular fluid. Okay, so these 3 you have to remember. Okay, how many carbon atoms do estrogens contain? 9, 10, 14. Okay. Okay, so this table is also important. Where table has gone? Okay, so this table, the carbon atom. So you must remember this thing that your estrogen is 18, androgens are 19, and progesterogens are 21. Okay. So 18, 19, and 21, and also the glucocorticoids and mineralocorticoids are also 21. Okay, so this is important carbon atom structure. Okay, now 16 and 18 are responsible for which percentage of cervical cancer? We have already discussed in a previous slide. So it was a 70%. Okay, so renal tubule originate from. So every kind of renal system is actually your 70. Yes, that's great. So every kind of your renal system is your originating from your mesonephric duct. Okay, so BRCA1 is responsible for which, how many percentage of cancers, like in breast and ovarian, they are. So you need to remember the percentages. These two percentages are very important in the BRCA1 and BRCA2. So BRCA1 is actually the breast CA 60 to 90%, ovarian CA 40 to 60%. Okay, BRCA2 is less than BRCA1, 45 to 85, and then ovarian cancer is 10 to 30%. Okay, so just pick the option from these. Like breast CA would be 75 option is correct because 60 to 98 land, and 40 to 60% ovarian. So it is actually less ovarian, but still you can select this option. If there is an other option with 40 to 50% ovarian cancer, then you can select that. Okay, so these percentages are important. You need to remember. We will cover 60 questions today. Okay, rest we will cover in our next class. Okay, so I think this question has been repeated again. Intense greenish frothy vaginal discharge. We have already discussed this greenish discharge and organism in scene. Yes, that was the first question. So the narrowest part of fallopian tube, you know that the widest part was ampulla and the narrowest part is isthmus. Okay, so which cell produces parathyroid hormone? So basically, parathyroid hormone is secreting from the parathyroid gland, basically. And with the two types of cells there, so chief cells or oxalic cells are there. So basically, it is secreted from which cell? No, C cells तो calcitonin secreting करते हैं. C cells are secreted by calcitonin. Chief cells are. So parathyroid hormone secreting by the chief cells. Yes. GnRH is what type of biochemical structure? This is a important one again. So these structures are also important for these hormones, and which is polypeptide we have discussed in our endocrinology. So you have to remember that, which are protein, which are polypeptides, which are steroids. So these kind of things are important. Basically, GnRH is your decapeptide. So this is very important. It's coming in 2-3 exams as well. So we will then do the rest of the questions. I think we have just approximately not full 200. So we'll cover the rest of the questions in our next lecture. Okay, so I need to know the availability of you because I will be doing this class in evening from 4 to 6 p.m. anytime from 4:30 to 5 mostly. So all of you are okay with that time? And what about the days? We'll be covering these recalls in 2 classes per week because we have to give 1 class to the crash course students as well. So that would be your revision class. And so 2 classes for recalls and 1 class will be for crash course students. So if you have any want to adjust the timing, you can tell me. But I think we have to cover in the evening. It will be comfortable for me as well. So are you people comfortable with that? Yes. Okay. Okay, so that's great. So with this, we end our today's class, and I hope you are much more confident now because these are easy questions. Basically, you just need to memorize them again and again and practice MCQs. Practice MCQ books. They are very important. Andrew Caesar's pass MRCOG. Basically, pass MRCOG is a little bit difficult for you people as well because when I see that it is A few things are not required in MRCG Part 1. They are giving you very details. We actually cover that in MRCG Part 2. So you are not going into very details of everything. That is actually the guideline portion is actually your curriculum of Part 2. So this is the basic portion. So you need to cover your basics would be in your fingertips. Okay. So I would suggest you people you should practice 2 3 MCQ books. So then only you can do the MCQs very easily. And recalls are just the practice of your MCQ, because you can have these wrong recalls as well. So I have just selected those which are actually the stem is complete, and then I can put an answer to that. But stem is actually important, so you have to have a stem. And also you get in MRCOG Part 1 you get pictorial diagrams as well. So few important pictures we will see from we'll take from Wikipedia, and then we will also do that as well, because I think 4 5 questions in both paper they are actually asking about the picture. So that is actually your anatomy basically. So anatomy they are asking in form of picture. So we'll be covering that as well in all this MCQ session. And I want you to just practice your MCQ books as much as you can. Okay. So if you have any question, you can ask me, or let's finish our today's discussion. No question? Or if you want to give any suggestion, you can give that as well. Okay, so no. Okay, so good luck for your exam, and let's end our today's class.